It's important to remember that most of our patients have early stage disease, right? And of those, most of them have estrogen receptor positive breast cancer. So this is a very large group of women in the United States and across the world for whom we need to be aware of our obligation to provide better treatments. So you'll see here the NCCN clinical practice guidelines in oncology with a focus on gene expression assays in making decisions about adjuvant systemic therapy. Over the course of our patients' treatment, we're making several decisions at different time points. Initially, a lot of it focuses on whether adjuvant chemotherapy would be beneficial. And to guide this decision, the most recognized, recommended genomic assay is the Oncotype, the 21 gene recurrence score. But later on in a patient's treatment, we're making additional decisions about adjuvant endocrine therapy. We're getting to the 4 or 5 year time point and trying to decide whether extending for another 5 years will be helpful to our patient in prevention of metastatic disease. And here you'll see that this is where breast cancer index fits in with an expanded NCCN list for genomic assays. It is the only one that is predictive of benefit of extended endocrine therapy. And so we're going to delve into that. So these predictive diagnostics will help us avoid both over and under treatment. So this is a figure that I show a lot of my patients. I pull it up on the monitor to drive a few points home. One, so this is from the Early Breast Cancer Trialists Collaborative Group publication in 2005 of tens of thousands of women who are treated with either tamoxifen for up to 5 years or placebo. And so one point that I try to make here is that the decisions that you make early on about adjuvant endocrine therapy have an impact on outcomes much later in the course of your disease. So whether you take tamoxifen for 5 years or not initially has a marked impact on your risk of recurrence at year 15. Another point that this shows, which is sobering, is that there's no magical 5 year time point where one can say, okay, you're cured, have a big party, that there remains this risk of distant metastases over the subsequent 10, even 20 years. And so we need to address that by modifying therapies and coming up with therapies that can address this issue of late recurrence. So if some is good, is more better? Well, this was looked at in several large trials of over 25,000 women shown in these 6 trials. So we have tamoxifen followed by AI and MA17 and ABCSG6A. We have tamoxifen followed by tamoxifen in Atlas and Adam. And then extension of AI in MA17R and NSABP B42. And what we see here is an absolute benefit of about 3 to 5% for extending endocrine therapy another 5 years. Great, right? But what that's also saying is that 95% of our patients don't benefit from extending therapy, right? Only 1 in 20 is going to benefit, and the remainder, the 19, do not. So how do we make these decisions to help figure out, who's really going to benefit? Well, many of us are providers, physicians, NPs, and so we gain clinical experience, and it's natural for us to want to try to look at what's right in front of us to help make our decisions. And so some of these things, come right off the pathology report: tumor size, grade, quantitative ER/PR, Ki-67, nodal status, the age of a patient, and even we're tempted to use other genomic assays because it's nice to just use one thing. Unfortunately, however, those factors, those clinical pathologic factors, can help us make an assessment on prognosis, but what they don't do is reliably predict the benefit of extending endocrine therapy. So we need a test that is able to do that, and so here we have breast cancer index, which can predict that benefit of extending therapy. So what is breast cancer index? Well, here it is. So it's actually two tests. There is a prognostic portion of the test and a predictive portion of the test. So the prognostic portion uses an algorithmic combination of 11 genes that are involved in cell proliferation and estrogen signaling, and assesses an individual's risk of late distant recurrence. So simply put, it's a percentage of recurrence between years 5 and 10. But the other portion I think is even more interesting, which is the predictive portion. And here we have a separate algorithm of a biomarker called H/I that are genes involved in estrogen signaling. So HOXB13 and IL-17BR. So a ratio that tells us a high ratio predicts a yes, a patient is likely to benefit from extended endocrine therapy, and a low ratio gives us a no, that our patient is not likely to benefit.